Thank you again for tuning back to Conversations with Us, a space where we discuss occupational therapy related topic. In this last segment, we continue to interview more occupational therapists based in South Africa and in the United Kingdom, and they continue to explore the changes in their practice as a result of this COVID-19 pandemic. Keep watching. I hope you enjoy. Welcome back to Conversations with Us, a space where we talk everything occupational therapy related. Next in our chat, our next guest is Karl Wellborn, an occupational therapist. Karl, I'll let you introduce yourself.
Hi, Petronella. Thank you for having me. So I'm Karl Wellborn. I'm a consultant occupational therapist specialising in neurological rehabilitation. I have been in healthcare for 19 years now. And have been working in the NHS and in private practice. The last 8 months has been solely private practice now. I've been building a company over the last 5 years nearly, which has afforded me the opportunity to really kind of go private full time. I have employed occupational therapists that work with me and for the company, and it's also allowed scope to develop other private services such as rehabilitation assistance and speech and language therapy. So that's me, I guess. I've many years in the NHS, leading a team in stroke and neuro, both hyperacute, acute rehab and through to community setting, as well as obviously the junior rotations.
Okay. So Karl, in your new practice, I know we were chatting earlier about in your new practice, and you're saying that you've started injection therapy or something different from the other OTs. So can you tell us more about the injection therapy?
Yeah, so I specialise in neurology, as I say, and in neurology, a lot of the clients I see suffer with spasticity and the management of spasticity. One way to manage spasticity is through the use of botulinum toxin, which was a service that was run with consultants and predominantly physiotherapists when I was in the NHS. For me, I found that I was assessing patients, I was identifying the spasticity, I was identifying the areas that were limiting patients' function, but yet I wasn't then able to inject the clients. They had to go elsewhere to then come back to me to continue to treat and to review. And there's a big push in occupational therapy to extend our scope of practice, to enhance our skills and to develop. And I felt this was one key way to develop myself and the profession. So I've recently, well, actually it's been over a year now, done a master's in injection therapy, as well as spent several years working in and out of clinics to gain experience. And now I complete paid work in clinics, injecting botulinum toxin as one way of managing spasticity for clients. I mentioned earlier, the next step really for us as occupational therapists is to start looking at how we can push to prescribe, because although I can now inject, so I can assess, I can inject, I can treat, I can review, I can't actually prescribe the botulinum toxin for the clients. So that then you bring in that external person who's never met the client and might only meet them for a very short period of time to be able to prescribe something that ultimately we could start to do as a profession.
Yeah, and that, I suppose, not being able to prescribe does limit your therapeutic input in a way.
It definitely limits the therapeutic input, and it can then cause a gap in the patient's treatment, because you could be waiting for that external person who needs to meet the client and to be able to prescribe the drug, where the outcome generally could, or most commonly, is exactly the same as it would have been if we were, as occupational therapists, allowed to prescribe. So the clients therefore have to wait, and it delays their treatment in essence.
Oh, fantastic. That's a very nice part of occupational therapy, or a different part of occupational therapy than what other occupational therapists are doing. Do you know, with your cases, do you see predominantly adults or children, or is it a great range as long as they have neurological conditions?
Yeah, so the practice isn't just exclusive to neurology. We do have non-neurological patients, but we do treat pediatrics, and we have a pediatric specialist, and we treat adults. So we try and cover as much scope as possible, really, within the practice.
Okay. So since, you know, like unfortunately this year we've had this horrific pandemic. Since the pandemic, has there been any changes in your practice or the way you carry out your assessments or intervention strategies?
Yeah, there's definitely been changes. I mean, early on, it came as a shock when obviously the pandemic broke out, and there was lots of concern and uncertainty amongst the population. It was unprecedented. In our practice, there was lots of consideration around risk assessment, obviously obtaining more PPE to be able to treat our clients. There was work that had to be done around making sure our clients felt safe for receiving treatment, but then also just generally safe anyway. Staff had to be furloughed because workload did reduce. Referrals, the referral rate slowed down significantly for at least a 2-month period. Some clients, although we were having telephone conversations and reviews, didn't want face-to-face contact because they were shielding. So that then caused a bit of an impact on the practice. We started using Zoom, as we are now, a lot more, and trying to use Zoom as a way of providing some treatment and rehabilitation. These are things that change. Some things are very positive. So like some things can be done via Zoom, as we've realized. And it got me thinking creatively, how can I make sure my clients are achieving their rehab goals as best as possible without that hands-on treatment or that kind of psychological motivation, I guess, that you get when you're face-to-face with your clients. And we started looking at equipment such as NeuroBall for upper limb rehabilitation and how we can support that via Zoom. Goal setting actually probably became a little bit better and a bit more objective, because we would set very specific targets for clients to achieve daily, weekly, monthly, and they knew they were going to be getting reviews regularly from their therapist. So yeah, it created a lot of challenges from practice, business, all areas, I guess.
And have you been able to fit in more clients or more patients now that you're using more technology, or do you feel like the patient ratio is just the same? It's been the same.
I mean, it was 2 months was the major lull, really. And then all of a sudden it got very busy. And I think what happened was the clients who were shielding or were apprehensive, they came to realize that their function ultimately was deteriorating, and they were then desperate to get the therapist in. And then obviously where we get our referrals from, referral rates started to go up, and it became very busy quite quickly. I think that so we've been seeing more clients of late. With the technology, I think that helps to a certain extent, but it's not hands-on rehab, which a lot of the clients really needed, I guess.
I guess it cut down that face-to-face contact with interaction with the client. So going forward, what do you think the changes that may remain going forward post-pandemic? Let's say the pandemic ends next month. Do you think things will just go back to the way they were, or do you foresee possible changes in the way that occupational therapists practice?
So what I've seen, I don't think things will just go back to normal. Some of the clients and people generally, and this is people who are normally fit and healthy, they've suffered because I think what we've found, and this is where occupational therapy is so integral, is we talk a lot about occupational identity, and the things that people do is what defines them. And unfortunately, all that has been taken away from a lot of people. They can't engage in their normal occupation, whether that be work, whether that be leisure, that social interaction, being out, having the opportunity to go out, feeling that sense of control over their life and the things they want to do. I think because all that has been, in essence, been taken away to some extent, I think there's going to be a big backlash of that. And I think mental health has suffered with a lot of people as a result. Physical health would have suffered. People can't go and do their normal activities, so there's going to be physical changes in their body. They're about to isolate. They've been at home. Nutrition may not be as good as it was. One of the things we do as occupational therapy is look at routines and habits, and we live, we're creatures of habit, and unfortunately all of those normal everyday 24-hour period routines and habits have been shaken up, and a lot of people have become at a loss as to what to do or how to do it or what's the best. Or I think that they've questioned lots of things within their own existence, I guess. So I think it's going to take a while for people to get back to how they were, especially people who have health difficulties. And then on top of that, we have the people obviously who unfortunately contracted COVID, and there's lots of now, we're finding out more and more each day, but I know in neurology, there's people who've had COVID and they're finding it's interfered with their neurology. So that's going to have an impact.
Yeah. Maybe the scope will get bigger for occupational therapists than it is at the moment. So yeah.
I truly believe so. I think one of the key things that we can see is the importance of occupation amongst people, whether they're unwell, injured, or fit. I think the importance of occupation has been highlighted massively during all of this pandemic, and the occupation's been taken away from people, or the opportunity to engage in normal occupation.
Yeah, no, you're right. I totally agree with that. But thank you so much. Is there anything else that you want to add before we finish? Unfortunately, our podcast is a bit shorter than usual, but yeah, anything else you want to add?
Not really. Just thank you for the opportunity to speak and to promote our wonderful profession.
Oh, thank you so much, Karl.
Good day, everyone. Welcome back to Conversations with Us. My name is Mapule Masamola Ralihika. We'll continue to discuss everything occupational therapy related. Next in our line, we got Ms. Petronella, one of the occupational therapists, also based in South Africa. Hi, Petronella. Welcome to Conversations with Us. How are you?
Hi, Mapule. Thank you for inviting me.
Okay. How are you today?
I'm good, thank you.
Okay. Petronella, what I'll do is I'll just let you introduce yourself, if that's okay.
Yes. So I'm Petronella Radzuma, as I've mentioned earlier. I'm an occupational therapist based in Polokwane in South Africa. I graduated from Medunsa in 2006. So I've been in OT for 14 years. This is my 14th year.
Oh,
and
wow.
Been in private practice.
You're old.
I feel old, but I've been in private practice. I think this is my 12th year. So I run a general practice. Mm-hmm. Our practice is 5 therapists, with therapists in different areas of OT. So we've got OT doing acute psychiatry, we've got an OT doing acute rehab in hospitals, and we've got an OT doing PEDS, and then we do medical legal, and we do FCEs. So we are a general OT practice.
Okay. So your referral structure, where do you get most of your clients from? Is it schools? Is it through the road accident funds, or is it a combination?
Sure. Everything, everywhere. So for our hospital patients, we're doing acute Psych, like I said, we do that in hospital, so that's referrals from the psychiatrist and the psychologist. And then we also do psych groups at the hospital, at the practice, outpatient psych groups, and that's referrals from psychiatrists, psychologists, some of the doctors that we work with, and teachers from schools for teenagers. And then with the children, our referrals also from everywhere. Word of mouth, I think with children has worked very well for our practice. So we got people that we treated years ago that are actually have spread
the word, yeah.
The good word for us. And teachers at schools do that, send a lot of kids as well. And then in terms of functional assessments, it's really just different government employers, some private employers themselves, and insurance companies. And then with the medical legal work, obviously it's just lawyers and the road accident fund. But I must say that I found, even in the midst of social media being the best form of marketing, I found that word of mouth has really worked for us. We're in a small town where I find that our target market, really, or rather most of our clientele, is people that don't really have time to be visiting, our fancy websites or going on our social media pages. So I've really just found that word of mouth has helped us a lot, and it still does. And those are the clientele. That's the clientele that we're able to, to retain.
Yeah. Oh wow, that sounds very, very good. Obviously, it says a lot about the services that you guys give. That's really good. And with regards to, like now during this horrible pandemic, when you compare how you see your clients now, because you have mental health clients, you got peds, you got a wide spectrum of clients, like you do general OT work. Do you feel like the way you practice now has changed compared to the way you practiced before the whole pandemic started?
A lot. So, for instance, before the lockdown, we would have, let me just give you a breakdown of what happens on a daily basis with the different therapists. So before the lockdown, our therapist that runs groups at the hospital would have groups with maximum, say, 10 people in a group. And that would happen from throughout the day. So we have a whole day program. Okay. And then post lockdown, the group numbers have to be very, very limited. And OT group sessions, it's all about being very close. We get all personal. So now the groups, the people have to sit very far apart with masks. So we had to adapt even the activities that we use in group sessions. It was a bit hard initially, but we kind of got used to it. And initially it was, we all sat and thought, are we going to get the same results that we want? But we eventually, worked around it. So that has changed in that aspect. So that means now, instead of having a group that has maybe maximum of 10 people, we now have 6, 7, and then we have a lot more groups instead of having one longer one with more people. And so the difficult thing with this really was just
has that effectively increased the time that you have to do the work because you're having smaller groups? So does it mean you have to run more sessions than before?
Yes, definitely. And then in terms of the children, I think for a while we stopped seeing children, and then when I think after the first 21 days, then we started seeing them, but also with all of our outpatients now. Fortunately, we've always worked on an appointment basis. Okay. But now our appointments are very much spaced, so they're very much far apart. And what I would do, I'm the one who's seeing the children now. So what I would do with the children before is I would start them all on individual treatment sessions. And then for the ones that I feel would benefit from being treated with another child or with 2 other children, depending on what their problems are, I would see them together. Now I don't do that anymore. So I see the children all individually, and the appointments are very much far apart. So that means we actually get to see less kids on a day that we see kids. And then we have work hardening clinics, which we have twice a week, every Tuesday and every Thursday. that ran for like 3 to 4 hours in the mornings. Now we take almost the whole day running the clinic because we have to put them far apart. And what we do with our work partnering clinic, we were not seeing the people individually. So we have like a big hall with different workstations. So the people would come. So now we have to limit that. And the other thing now is that most of our, not most, like maybe 30-40% of our clients that were coming for the clinic it's people that were injured on duty, so their employers were bringing them to the sessions. And some of them can't afford to, they live far, they can't come to town. So, and not all government departments or whatever, some employers have fully reopened, and some, as you know, have already like retrenched staff. So there are those patients that we had that were in the work hardening program that couldn't come back because the employer is not able to provide transport anymore, or they're not open anymore, or the driver hasn't come back to work. So we've got a lot of people that have just been hanging since the lockdown started here, and that's a bit of a problem. And, you know, with what we're doing, I personally find it challenging to have therapy with them online, you know. But the fortunate thing was that with all of the people that come for the work hardening clinics, every day when they leave, we've got some little home programs that they get. So they continued with that, but because it's like a set program of this is the number of sessions and it should be done by, you know, a specific time, the home programs are supposed to be upgraded or improved or changed. So so we do have a huge group of patients that are just at home stuck. We don't also know what to do yet, but we're planning with employers what would be the best way to go forward with those. And then with our patients that are in general hospitals, there we really don't have problems because the hospitals are very strict in terms of PPE, what should be done, and, you know, different wards have been demarcated, and so there really we're not really worried because the hospitals enforce
the safety and the hygiene.
Yes, and PPE in the different wards that have been zoned and so there we're quite confident and happy. And then schools, we don't go to schools anymore since the lockdown. Also because I think the return to school with a lot of the schools around has been very inconsistent. Some of the kids are back, some are not, and some are going on certain days. So that also just is on a standstill still. Yeah. So with all the we had in therapy, we've kind of put it on a standstill. But the ones that we were seeing from the practice, as I mentioned, the parents are able to bring them. The appointments are just very much far apart, and the ones that I would like to see with other kids, I can't anymore. I see them individually.
Okay. And you spoke earlier on about use of technology. Have you guys started using technology and also other aspects like home visit? Do you do any home visit to those people or site visit to people's work, or is it mostly they come to the practice?
So most of them come to the practice, but we do work visits. We do not do home visits anymore. And it was prior to the lockdown that we had made the decision not to do home visits. But work visits we still do. So the work visits are easy also because then we plan, we arrange with the employer and they would tell us, so before you come, this is what we expect, and this is what we're implementing since COVID in our company if you're going to do a work visit. So then we just follow whatever the expectations are.
Okay, so they've got their own set of protocols in place at the that's good. It gives you a little bit of peace of mind from your end. Yeah. Yes. And what about technology? Have you guys started using technology at all? How do you see technology fitting into this? Do you think it's going to work or not? Or
I think if this continues, it will have to work, but it's a bit of a challenge because very few of our people have got access to internet, and even those that do, really using resources like Zoom or FaceTime or anything, it's still a bit of a challenge for most people. I mean, most people, I think myself included, for the longest time, what I want with my phone is to receive calls, make calls, send messages, and receive
And go onto
messages.
social media.
Yeah, if you like me. But yeah, but I think if this persists, we will have to. But so far, we haven't really done that. It would just be telephonic consults, and it's not even. It would be okay. So we can't make it for the session. What do you think we should do? Then we just give them like a program, or we plan, or we schedule. Okay, we're going to talk to your employer, and then we'll give you feedback. So for most of the patients that couldn't come back, we're still in a planning process in terms of what do we do going forward. But to be honest, in terms of full-on therapy using technology, we haven't done that.
We haven't done that. And to be fair, I guess at this point it only works up to a certain extent, but it has its own limitations. Yeah, but we never know. That's where the world is moving to in the future. How do you see the future of OT?
Ooh, okay, I'm one of those crazy OTs, so I'm going to tell you I see it as bright as ever. I think OT has so much potential,
Mm-hmm.
and I think that a lot of people, and I get more excited when it's younger people are becoming more aware of what OT is. And the minute they realize that OT is so broad that it doesn't confine you to a little box or one specific thing, they get more excited about it. So I think in general, I see OT growing, people understanding it better and more and loving it. But my a dream or goal really is just to inspire a lot of existing OTs, young OTs, to just be passionate about OT.
Yeah.
There are really so much potential in OT.
Yeah, and the scope is so wide as well. The scope is just very wide for OT. If you don't like working in a certain area, you can always move to a certain area.
Why we have general practice, because we don't like boxes. So the peds OT, psych OT, medical legal OT doesn't work for us. So for instance, like I said, I'm doing peds this year, and before we started doing peds this year, I think I had gone for 3 or 4 years without doing peds.
Oh wow!
So, yeah, but
came back.
For the longest time, I think I did peds and other things, and then got to a point where I would feel like, okay, now maybe let me do medical legal. And maybe now let me do voc rehab, let me do this. So it's for me, it's just the ability to choose, from our own practice what I want to work with. It's just so fulfilling.
Yeah. Oh wow.
And I think that's what makes OT so interesting.
Yeah, it definitely is. Definitely. It's quite nice to be speaking to someone younger than me, very passionate about OT. And, thank you so much for getting involved. Maybe in the future, or if anyone in the Petersburg area, that's looking for an OT, they'll definitely be able to search you and look you up. Yeah.
Thank you so much, Mapule.
What's your practice called again?
It's called Mobile OTs, Occupational Therapy.
Okay, Mobile Occupational Therapy, everyone. Thank you so much for tuning to Conversation with Us, a space where we discuss everything occupational therapy related.
All right.
As we conclude this topic, I'd like to thank everyone who kindly participated in this segment. Please tune in for our next segment, which is Occupational Therapy and Other Allied Health Workers. Please like, share, and press the red subscribe button for more episodes. This is Mapule Masamola, and thank you for watching Conversations with Us, a space where we discuss and explore occupational therapy related topics. I thank you.